Good evening, everyone. Thank you so much for making time to join us for today's CME. Very excited to have our speaker for the day. I'm Dr. Wanjiko Mode. I'm a consultant ophthalmologist. It is my pleasure to invite Dr. Geoffrey Kome, who is an ophthalmologist at the Meru Teaching and Referral Hospital. And he'll be a moderator for the day, and he'll introduce to us the speaker for the day as well. Dr. Kome, karibu sana.
Thank you so much. Good evening, everyone, and welcome to today's CME. It's yet another opportunity to enlighten ourselves and to get informed of what is happening. For today, we are pleased to have a presentation by an ophthalmologist. So get ready to hear what today's topic has for us and learn, ask questions, and get enriched. Remember to stay muted during the presentation. And in case you have any question, kindly use the chat to post your questions, comments. We will address them during the Q&A session. So we'll have the presentation. Then after the presentation, we'll also have a short session by our chair of the OSK, Dr. Mateda. Then thereafter, we'll have a session on Q&A. Allow me to introduce the speaker of the day. The speaker of the day is Dr. Sisomo Griffin Firi, a clinical cytologist and a cytopathologist trained at the University of Nairobi. He is currently based in Malawi, where he serves as a part-time lecturer at the Kamuzu University of Health Sciences. Dr. Griffin is deeply passionate about advancing cancer diagnostics with a particular focus on minimally invasive techniques such as fine needle aspiration and impression cytology. His academic interests span cancer research, molecular diagnostics, and improving access to pathology services in low-resource settings, where their innovation and impact are both, where they are urgently needed. Today, Dr. Griffin will be presenting findings from his MSc thesis titled Evaluation of Impression Cytology for the Diagnosis of Ocular Surface Squamous Neoplasia, that's OSSN. This work holds a special significance to him as it was carried out under the mentorship of some of the Africa's leading experts in the field. As you all know, Professor Gishi has done extensive studies in this area. We also have Dr. Mnene and Professor Moshiri. In future, Dr. Firi hopes to go deeper into the molecular biology of OSSN, contributing to the growing body of knowledge to support early diagnosis and improved patient outcomes. Please join me in warmly welcoming Dr. Griffin for this presentation. Welcome, Dr. Griffin.
Thank you so much, Dr. Kwame. I'd like to thank everyone for this wonderful privilege to be amidst you, ophthalmologists, and to share my findings for a study which we did last year. So it's quite an honor and a huge and massive privilege to be among you. And I'm also excited when I had this invitation, and I'm willing to share my results. So, like Dr. Kwame has mentioned, my name is Dr. Chisomo Griffin Pivi. Yeah, so I forgive him for the pronunciations. You know, it's from another region of the continent, but yeah, you had it right. So tonight I'm going to present a study which we did last year, titled Evaluation of Impression Cytology for Diagnosis of Ocular Surface Squamous Neoplasia in 2 Kenyan tertiary hospitals. So we are lucky and happy to share that we published this these findings or this study earlier this year. So we did the study last year and we published it this year in April. So in Cancer Investigation Journal, and I'm going to share the link with Mercy so that I can also share, because we have omitted some of the sections in the presentation so that we are more biased to ophthalmology than the pathology side. So, but the whole matter, you'll find it in the journal and the link which we'll share for further studies and details. So I was privileged also to work with, like Dr. Kome has mentioned, the African champions in advancing, in OSSN. So I was really lucky to do that and to be housed in KNH and also in Kikuyu hospitals. So it was quite an honor, and I'm so happy to share the presentations today. So before we start here, I would like to mention that I'll be using OSSN for ocular surface squamous neoplasia. So whenever I mention OSSN, that's what basically I mean. So let's begin. So to start with, a brief background about OSSN. So this shouldn't be very new to all of us, but it's a spectrum of conjunctival and corneal diseases, which includes the intraepithelial dysplasia and invasive squamous cell carcinoma. So basically, the clinical signs are large feeder vessels, which you usually see on the slit lamp, and which are depicted here by the arrows. And you have leukoplakia, and you have general redness of the eyes, and you have inflammation, and in some severe cases, you have this papillae forming. So generally, these are the major signs of OSSN in patients. So its major risk factors for the condition, it's ultraviolet radiation or UV exposure, HIV virus, and a human papillomavirus as well. And of late, recently, it's been also noted that allergic conjunctivitis also predisposes one to OSSN. So globally, the highest incidence is in sub-Saharan African region, and it's noted to be aggressive in HIV positive patients. So it's very common in young women, according to recent studies, in the sub-Saharan African region, and in temperate regions like America and Europe. It's common in older men. Excuse me. So no wonder there's little literature about OSSN. It wasn't quite extensively studied in Europe because it was only noted in older populations. So the major chunk of this presentation is we're about to talk about impression cytology. So we're going to delve a much into diagnostics. So for you ophthalmologists to diagnosis basically or mostly it relies on clinical impression. So when you go on the slit lamp and you see the signs I've just showed here, or some of them, especially just larger feeder vessels, you almost conclude that that's OSSN. However, this is unreliable because some benign conditions like pterygium, you can also present the same. So it's very unreliable. No wonder it's very important to have lab diagnosis on the same. All right, so our current diagnostic modalities include anterior segment optical coherence tomography. This is the latest technology, very important. And we have vital stains like toridine blue, rose bengal, those stains, vital stains, which basically stain the DNA. We can use them to diagnose for diagnosis. And we use cytology, which we'll talk much of it today. And we have histology, which is the gold standard. So, however, not to diminish the gold standard, but of late we know that our gold standard has a few limitations where we know that it requires surgical interventions. So sometimes our patients may not be fit for surgery, so that becomes a limitation. However, it's to also access histopathological services, a little bit costly, and that may lead to a little delay in diagnosis. And another second major disadvantage or limitation is that in areas affected most or hit with highest burdens of the OSSN, there's almost unavailable or limited access to histopathological services. So that makes it another limitation. So a little literature, I was trying to compare different diagnostic modalities and how they perform in diagnosis of OSSN. So a study done in 2015, it was noted that using just clinical appearance, or there's background noise. I think proceed. So using clinical impression or clinical appearance only to diagnose OSSN is added to about 50% chance. So just using the clinical impression, you have a 50-50 chance to make the right call for OSSN. And to use the vital standing, whoever is making noise in the background, we kind of ask that they mute.
I've muted them.
So, thank you. So using the vital stands, for instance, tweed in blue, we found that there was a positive predictive value of up to 41%, and which is not very promising, and negative predictive value of 88%. So this was noted due to a lot of false negatives. So it means the region was able to take the dye, but even benign conditions were also taking the dye, so making the vital stains not very reliable. So the ASC Opt, the new technology, very sensitive, 100%, highly specific, 94%. However, it's costly and almost unavailable in most areas, making it a difficult option. So for another study in 2003 by Dr. Munene and colleagues, they were using impression cytology, and they found that the specificity was up to 96%, and they had about 98% cell harvest, making impression cytology quite reliable. So today we're talking about impression cytology. What is it? What's it all about? So like I mentioned, it's a technique for collecting cells from the superficial layers of the ocular surface. So its key advantages are that it's minimally invasive, it's easy to correct and pretty much safe, and it can be performed on outpatient basis. So it's very useful for screening, and also you can use it for post-treatment follow-ups. But its major limitation, it's that it only samples the surface area, or the ocular surface area. However, what we've noted is that the disease initiates in the deeper layers or the epithelium. So as years pass, the disease keeps advancing to the top until it gets to the ocular surface. So that makes it a little bit less advantage, because it only samples the ocular surface. So that's its main disadvantage. So our main objective when we're doing this study, we wanted to compare the impression cytology with our gold standard histology in diagnosis of OSSN in two institutions, Kenyatta National Hospital and Kikuyu Hospital. So we had two specific objectives. The first one was to classify OSSN into diagnostic categories using a modified Bethesda system for reporting cervicovaginal cytology. So maybe you'll be confused, like, why are we using cervicovaginal cytology now? Okay, so the thing is, the epithelium on the ocular surface and that of the cervix, it's literally identical. So what the presentation, the pathological presentation of the epithelium on the ocular surface and the vagina, it's literally identical. So we opted to use this system, which is a standardized system, which is used for scoring cervical cancer. So we just modified it and to use it for, of course, with backing from literature, and to classify OSSN into different diagnostic categories. So the second specific objective was to determine the sensitivity, the specificity, and the negative and positive predictive values for impression cytology against histology. So you know these sensitivity. This is basically accuracy. You know, these are statistical measures which we use to evaluate the performance of a diagnostic test. In this case, our impression cytology. So this was a diagnostic accuracy study which was conducted at KNH and Kikuyu hospitals, and we had a population of 40 patients who were at least 18 years and above, who were presenting at the eye clinics and were already suspected of OSSN, and they were scheduled for a biopsy. So we targeted people who were already scheduled for biopsy or who were about to get their biopsies done for to confirm OSSN. So that those were our population. All right. So the procedure, I thought this was very important. I wanted to mention, I wanted to underscore this one because it's. I'm hoping that from this people try this, and you should do this actually. So the very first things to do is to get the materials. What you need is cellulose acetate strips. You needed conjunctival forceps. You need alcohol yes, alcohol at 95% alcohol, and yeah, pretty much in the lab. So, but the three major things you need to have in your clinic. So what you do, the first thing we did drop of topical anesthesia in the eye, and then we had the cellulose acetate strip, and it was smoothed onto the ocular surface for about 5 to 10 seconds. Then you took the strip. For me, I was personally doing 4, and you put them in the 95% alcohol. So later, these were stained using a perpendicular stain, which is very good for squamous cells. So, and later we classified it under the microscope in the lab. We classified squamous cell abnormalities using the standardized modified Bethesda system for reporting cervicovaginal cytology. So this is just to show you what we are doing. So this was our patient. So Dr. Munene told me to cut because you don't need too much, you just need the strip. So I had to cut the strip to adjust this size. And these are the conjunctival forceps. So you touch the lesion for about 5 to 10 seconds, like I mentioned, ensuring that the patient is not blinking and ensuring that there's not a lot of tears. Yeah. So after that, you remove. So you literally like peel off, and then you immerse it in your 95% alcohol. So from there, it's sent to the lab where it was stained using perpendicular stain. Then at the end of the day, it will be mounted on a glass slide. So this was one of our samples, and it will look like this. So this was ready for microscopy and the classification for later. So after we did all that, we gathered the results. So we found that the highest frequency of patients was falling within the age group of 37 to 45 years old. So like the previous studies, like I mentioned earlier, that the burden is seen mostly in women and also in the younger population. So you can see an average of 37 to 45 years. So this is against the norm of what the book says, that you often see this case in older men, older persons, and there are also men. So like you can see here, we had, yes, the older populations, but it was almost in all the patient groups, we had a significant skew towards the female patients. All right, so presenting symptoms, not almost all patients had redness in the eyes, irritation, itchiness. A majority had ocular pain, and 88% reported some discharge, and 83% reported some decreased vision. So you notice that less people noted that we had the protrusion of the eyeball, and they had the leukoplakia. So when we did the cytology, we had these results where about 58% of the population were scored as negative, and 17.5% was scored as squamous cell carcinoma, which this was positive. It meant the patients had OSSN. So for this group, HC, basically means high-grade squamous interepithelial lesion, and this is low-grade squamous interepithelial lesion. So these are pre-invasive or precancerous lesion. So if these are not managed, they progress to squamous cell carcinoma. So there's another group, 7.5%, which we reported just as atypical. So this is a sensitive group also to me, because when the cells were just presenting as they're just atypical. So you aren't sure if are they positive. Definitely they're not negative, they're just atypical. So you can't literally call them to be part of the pre-invasive or precancerous lesions, but they're just there. So, however, I'll mention the significance of why these were important probably in the next 2 or 3 slides. So I didn't need to put this. I just wanted you to appreciate this is what we see under the microscope. So this is what a negative result would appear. So I don't want to explain details, but just you to appreciate that this is what a negative result would appear. And a low-grade lesion would appear like this. So there's a way we score them. We usually mention the nuclei and the cytoplasm, the loudness, and all that. So this was just atypical. It was just bizarre. You're not sure what it is. And so to my right, this is typically what is OSSN. This is squamous cell carcinoma. Actually, this was keratinizing squamous cell carcinoma. So yeah, just for you to appreciate. So what we are basically doing, we collected the samples, and the patients would continue the procedure. They'll go for their biopsies, to go for histology. So whoever was screening the histology were branded of the results of the IC or the impression cytologist, because it was us. You know, the results of impression cytology will be out the same day or the next day if you're lazy. But we collect the samples today, process them the same day, and have results at the end of the day. And for histology, you have to wait. So we'd wait, and now we'd compare. So when the histology results came, so we found that 70%, the histology caught 70% of the population as negative, 20% as having OSSN, and 10% as having pre-invasive regions. So we did the statistical measurements where we were doing the impression cytology against the histology, and we found that there was a 30% prevalence of OSSN in our population. This is at 95% confidence interval, and we found that the sensitivity was 100%. So this meant that our test or impression cytology was able to identify all patients who had the disease. So that means we didn't have false positive results. And 82% of we had specificity of 82%, which meant that the test correctly identified 82% patients who had the disease. So it missed some. So now that takes me back to where the group I was just calling atypical. So those are the people we missed. So we had 71% positive predictive value, which is really good. And this meant that the probability, or at least the chance, the 71% chance that someone has OSSN, if IC says someone has OSSN, they do have it. And we had 100% negative predictive value. So this definitely meant that if IC calls that someone does not have OSSN, then most likely they do not have OSSN. And we had a wonderful positive likelihood ratio of a score of 5.6, which meant that 5.6 chances that if someone has OSSN, then they do have it. Yes, so, and we also did a ROC curve, a receiver operating characteristic curve, and it had about 0.91 area under the curve, which meant that the probability of correctly distinguishing a positive and negative case at 91%. So this is high confidence, which is really good. So our discussion is that the median age was about 50 years with a predominance of 70% females. So this was also in tandem with what Geshuhi and colleagues discovered in 2013, where they had about 37% median age and about 66% also of female predominance. So these results were married. So we had about 57% of participants reported that they spent at least 4 hours per day for outdoor activities. So studies by in Ghana and Kenya also, by Gishuhi, of course, they did not pretty much the same, that spending more time outdoors or outdoor activities and living and below the equator and in the sub-Saharan area was associated with high risk of OSSN. So another thing to note was that all the patients we had in our cohort, they did not have a family history of cancer. So this meant that the hereditary factors play a very minor role in OSSN. So it can be spontaneous. So probably that's another area which we need to study further to understand how and why we would have OSSN in a population with no family history of OSSN, of cancer, any cancer. So we also noted that the OSSN was classified into diagnostic categories using this modified Bethesda system for reporting cervicovaginal cytology. So we concluded that there's a good correlation between the modified Bethesda system and histological reporting. And we also noted that impression cytology has a lower false negative rates in settings where neoplasia are typically advanced or evolved or theirs. So what that point basically means is, because like I mentioned, that the OSSN usually starts at the deeper layer or the deeper epithelium and advanced with time. So it means when it's full thickness, when the OSSN or the disease has advanced into full thickness, then impression cytology will definitely pick it up. But maybe when it's just 1/3 of the thickness, impression cytology may report it as a low grade or a high grade lesion or a precancerous lesion or basically atypical. But now the same patient, when you do histology, will be reported as positive. So like I mentioned, that's a limitation of IC, and that it only collects samples from the ocular surface. So histology, again, still remains the gold standard to make the definite diagnosis. So due to its high sensitivity and negative predictive value, a negative IC results then almost certainly rules out OSSN. And that is very important and good for us. So a few recommendations we had after the study was that if possible, we should adopt impression cytology as the first line screening tool. So we want to have it as a screening tool. So whenever you're on the sit-ramp, you've had all the cases like I mentioned, all the symptoms or the signs, then you can just do impression cytology before you refer a person for a biopsy. That is an invasive procedure, So we are asking for adoption of IC as a first-line screening diagnostic tool. So we also wanted to say we want to promote the use of impression cytology in regions which we have limited access to biopsy facilities. Because personally, later I've had contact with many ophthalmologists, and majority of the friends, they mentioned that they don't have access to histopathology. So actually, they just when they make a clinical impression and they just start administering the drugs. So we can do this because like I mentioned, it's very easy to perform. You can literally do it outpatient, and for us, pretty much half of our patients, we collected the samples in the clinics before and they went in the theater. So the other half we collected on the table. Just I do the sample collection and the patient continued to have the biopsy done. So we are also asking if to incorporate a standardized, now we want to have at the end of the day, a standardized impression cytology score for diagnosis of OSSN in cytopathological laboratories, and want to ensure this standardization so that we have good communication for reporting and good certification. So basically, that's what I had for you tonight, and we want to acknowledge the staff at KNH and Kikuyu Hospital, and for their support and the patients which participated in the study. And we did not have any conflicts of interest in the work. Thank you. Now I hope it's open for questions and comments.
Okay, thank you so much, Dr. Griffin. You said your name is Piri, not Piri.
Yeah,
thank you. Okay. Thank you for enlightening us in this presentation towards diagnosis of OSSN. I think you have brought the message home on impression cytology. Kindly let's post our questions, comments in the chat. Meanwhile, I welcome Dr. Matede for a short presentation, then we'll go back to the Q&A session. Welcome, Dr. Matede.
Thank you very much. I don't have a presentation, just an urgent member announcement that needs to be made. And because of something urgent, that's why I requested to be done now. All of us are aware that we are working hard to make sure we have a successful conference this year, planned for Malindi. I can see Oscar is very excited. But that's the reason why I'm actually coming to you members with an urgent request to make that practical and workable. So pardon that is coming in between the questions. Two things have come up. The conference facility has actually been identified, as most of you have already seen now through the prospectus. Is a Diamond Hotel in Malindi. We definitely dates are remaining to 28th November. Now we're in the motions of making sure that becomes practical and workable. And it's in that line that we are getting some urgent need from you members to be able to make it practical and workable. We definitely have found out the conference facilities, yes, but you can never have a conference without accommodation. And Malindi is presenting an interesting challenge, being a touristic town more than it is of a conference town. Rooms are proving to be a challenge, and we're having a struggle with the hotel to try and secure rooms in time for us, or for a longer period, to be able to make it available to members at pleasure. And that's why I've requested to come forth to you so that I can actually bring this to your attention for your help to make it practical. So far right now, until this evening, we've been trying through the able hands of Dr. Brenda. She's been busy with them, and I can assure you it's been a nice headache for her to try and get some of the deals we are getting. So far getting negotiated rates, which are not really very sweet. I would have wished them to be lower, but unfortunately that's what they're offering us. A single room for about 13,000 shillings per night, and around 20,000 for a double. The challenge is that these rooms need to actually be booked the soonest possible, because the hotel is insisting on having them booked in time. Otherwise, they'll be open up for anybody to book them. And interesting enough, they're actually moving very fast. So far now, the only rooms we have available are about 76 to 80, which are moving very fast because the hotel is selling them out to the ones who are buying them. November is actually a high season for them because it's cold in Europe. So most of these gentlemen and ladies in Europe come to that region. So my call to you is that you will be getting a call from Mercy office to sometime between tomorrow and most of the tomorrow, trying to request you to confirm if you are attending and if practical, which is my plea to you. Kindly book. Otherwise, we'll be having a conference and we'll be struggling to get you accommodation. And like many other cities, Malindi doesn't have so much liberty of rooms. And yet we've secured all that so far. And I don't think we have enough time to go looking for another facility or another conference facility elsewhere. So my plea to you through this is to first be willing to listen to Mercy if she calls you, number one. But Mercy's job is simply to remind you, basically to put pressure on you. If you're able to, if you choose to get a room, please kindly book it within the period that the hotel is giving us. Because outside that, which I think is about a week, which is why I'm actually talking to you, is actually a short, very short notice. The failure of that, it means that the first come, first served for not secured by OSK at all. So kindly, please, for those of us, and I believe it's all of us, who will be available in Malindi, between tomorrow and that week, we will be getting information both on the website and on the WhatsApp group. Practically, please book. They require about 40% down payment to secure the room and protect them from us. Other than that, I think I'm enjoying the presentation. Thank you very much, Piri, so much for that wonderful presentation. I think it's something that needs to be adapted practically to make life, our impact on patients' care much better. I think with that, I will leave it at that point and only encourage you when you see Mercy's call, please pick it and help and answer the question she'll be asking you to do that. Thank you very much. Back to the moderator.
Thank you so much. We go now to Q&A session. Some questions have been posted already. I'll go to Victor is asking, what is the difference between impression cytology versus histopathology in terms of the sample to submit and the procedure? Do you still excise the suspect lesion in total as we do for histopathology and submit for impression cytology? And you say, thanks for great presentation. Dr. Griffin, kindly you can respond to that.
Thank you. So thank you, Victor, for your questions. So to begin with, the difference between impression cytology and histopathology, like you mentioned, it's in the samples. Because with histopathology, we basically correct a biopsy. So you have to make an incision or an excision sometimes, but you make an incision where you have to correct some flesh, and you submit that sample. That's histology. So for impression cytology, basically we have a strip or a paper, so which we touch an area which we suspect has the disease. So basically it's just like to touch imprint, where you just touch an area with a paper and you remove the paper. So basically the flesh is still there, everything is still there, but in ideal sense, we have just removed the surface or the cells on the superficial layer. So you submit now the paper, which we believe that it has cells stuck to it. So that's the major difference. So the other question was, do you still excise the suspected region in total, as we do for histology, and submit for impression cytology? I think that I've answered. You don't excise everything. You're just basically touching. So no wonder the word impression. So you have this paper, you impress on the surface, and you submit the paper. So basically that's that. Thank you.
Okay, thank you. Mary, thank you for the presentation. When was the study done?
Thank you, Mary. So for the study, we basically started it in 2023, end 2023. Basically just brainstorming with Prof. Kishuhi. Then later we did conduct it in 2024, earlier in 2024. Yeah, basically, so I would say it was conducted last year. So because that's when we did the sample collection, the writing and everything. So 2024, last year. Thank you.
Thank you. Mashep is saying, thanks really for the presentation. If you have already done a biopsy and histology confirms OSSN, can you use impression cytology for follow-up to check for recurrence? If so, what frequency is recommended for the different grades of OSSN? Thanks.
Thank you, Alex. So, yes, actually, one of the things which prompted us to do this study was this this very reason, because at the end of the day, we want to try as much as possible to not expose patients to, we want to expose patients to minimum harm. So as much as possible, we want to, if possible, not expose harm to patients. So for follow-up, unfortunately, the routine is, even if you want to do follow-up, you still have to do the biopsy on the same. So, but with impression cytology, you can do impression cytology as follow-up. So the follow-up will continue as long as impression cytology keeps saying negative, and then you can give it another year or two. If the patient was confirmed to have OSS sign, then you can always do yearly. But if a patient's never had OSS sign, then we push it to 2 years or 3 years. That's the spacing, but that's the frequency. So yes, but if now during follow-up OSS, I mean impression cytology reports, let's say high-grade lesion or reports positive, then again you have to go through histology to confirm the grade. So with the impression cytology, the grading is basically on the level, not the full thickness as we do in histology, because we have 1/3, 2/3, 4/3, I mean, or the full thickness. So with impression cytology, basically it's just yes, you have cancer, or you have precancerous conditions, or you do not have cancer. So I think that kind of answers it. But I'm open if you need clarification, honestly.
Thank you. Yes, Siko is asking, where can the cellulose acetate be procured from? Is it costly?
Okay, thank you, Chiku, for the question. So initially we thought it was readily available. So I remember I was asking for Fishuhi and Dr. Munede, we really thought it was readily available. And most websites, when I was in Kenya, when I was checking most Surprise, it was literally there. But when we went to the Surprise, we didn't find. So, however, but it's readily available because I remember I shipped mine from China using I've forgotten the company, but it was very cheap. It costed me about around 5,000 shillings, less than 5,000 shillings, but we're able to secure a lot more than necessary. So some I left there and shared with other ophthalmologists, but it's not that costly. So yes, but the only thing is you have to prepare in advance. I don't know if it's now readily available in Kenya, but last time we struggled. Not only in Kenya, I didn't find it in Malawi also. I didn't find it in South Africa, and I didn't find it in Tanzania. I also checked with Tanzania. So yes, that's that.
Okay, thank you for the answer. Vicky, the costs. So if it is not readily available, does it affect or make sense now that your studies on low resource settings, in terms of cost availability? How do you comment about that?
Okay, so to mention that, I think you know there are two ways to view this answer. Number one, it could be me because you know I was new to Kenya then, so I wouldn't know all the surprise, all the right surprise. I was literally relying on internet to search for the surprise around Kenya, around Nairobi, not Kenya, but around specifically Nairobi. So that is one part. The second part is it's not commonly used. So because until we make this common practice, until maybe one or two people keeps prompting, like you prompt the surprise, maybe they'll be like, okay, let's procure these things. But if you order outside outside our region, then it's readily available. You in China, like in 2 days I had it. I don't know, did I use AliExpress, Alibaba Express? I think I used that. Sure.
Okay, thank you. Joy is saying, thanks for the good presentation. Lena is saying, great presentation. What informed 40 patients? Why Kenich and Kikuyu hospitals?
All right, thank you. So initially, the study wanted to conduct it solely in Kenyatta National Hospital. So remember, so to say, I was a student and I was chasing deadlines. So there was that part. So I was unlucky that the moment we started the study, after just like collecting 3 or 4 patients, we had a strike, which was like about 2 months. There's a doctor strike, so it meant we almost having no patients. So we had to did an amendment where we extended to Kikuyu Hospital. So that was number 1. Number 2, basically it was with a short span and the availability of these patients. You don't get to have people coming for OSSN every day. So it meant it would have required for me to maybe study for over a year to get big numbers. So when we did the using the previous study by Prof. Kishuhi, using that previous study, so we narrowed it down to the lowest sample size, and that's where we got to the 40. So we're using the previous from the previous study by Prof. Kishuhi and colleagues. So it's basic statistics.
Sure. Okay, thank you. Joy is asking a comment. This might be useful for patients with advanced disease, which would require extensive surgery. We often do incision biopsy to justify the life-changing surgery and help the patient accept the treatment. Reliable cytology would be faster and more cost-effective. Please share your Malawi contacts.
I will. And a big shout out and a big thanks to Dr. Joy Kabiru. She was the person who was housing me in Kikuyu. So I was on with her for about a month. So when I was working with her, so it's an honor and thank you, Kabisa.
Okay, thank you. Kindly, if you have a comment, a question, you can unmute and ask before we conclude. I think we have a diverse group of in attendance. If there's any question, kindly comment even on the research methodology. We also have 1 minute. Thank you. Mulid is asking, thank you for the presentation. Can impression cytology be used to know treatment response? Were you able to check correlation between clinical features versus histological agreed and IC results?
Thank you. So can impression cytology be used to know the treatment response? We're able to check the correlation between clinical features, histological grade, and IC results. All right. So with the to monitor treatment response, yes, there was like I mentioned. So let's say the patient's their first visit to the hospital, we had a biopsy done, and yes, they had OSSN, so they're on treatment. So on the next visit, before we subject them to another biopsy, and then we do, because there's also, as I already mentioned, there's recurrences, a lot of recurrences. OSSN usually recur. So you do the impression cytology again, then it's negative. Or in the first instance, it was positive, then it's showing maybe atypical. So you can best believe that the condition is recessing. Then after some point, they come for another follow-up. So like I mentioned, basically the closest you can do is 3 months. So 3 months apart. Because if you do the impression cytology today or the biopsy today, and you do the IC within 2 months, then you have atypical results because of the inflammation, the area is healing, so there's metaplasia, so that results in atypical results. So ideally, we want to space a minimum of 3 months to 6 months, and if the patient never had a positive OSSN results, both IC or histology, then you can do at least a year spacing. So yes, if the patient has been receiving treatment, then probably theoretically we believe that it will be showing atypical, then later it will show negative. In some instances, when it's recurring, you can have a negative IC result today, and maybe in 3 or 4 years, then you have a positive one. So like I mentioned, it's good that we further study this probably at a molecular point, so that we understand the nature and the behavior of this. So the other part was, were you able to check the correlation between the clinical features versus the histological grade and IC results? So the correlation basically we did between the pathology only, the histological and IC results, because like I mentioned that unless I'm not understanding the question, but the clinical features usually they're deceptive. So because I remember with Dr. Monene, we had a patient which had pretty much the papillae. So from the clinical impression, you are very 100% positive that this patient has the OSSN. So when we did, it was negative, and histology was also negative. So the clinical features sometimes may be deceptive, and so again pushing to the lab testing, to the histology to be the gold standard, and the IC to be the adjunct alternative. I don't know if that's clear, but yeah, thank you for the beautiful question.
Okay, thank you. I would like to give this opportunity to Professor Gishui and Dr. Mnene to make a comment. As you had during our introduction, we have Africa's leading expert in the field. Dr. Mnene and Professor Gishui, kindly, the floor is yours for a comment. I want on the same.
Bluetooth. Good evening, everyone.
Good evening.
My comment would just be on the way forward now that this study has been completed. At the end of this, we had a meeting with the head of pathology in the hospital. And what was agreed on was that since we still have so much cellulose acetate paper remaining, we need to look at a way of continuing taking impression cytology with routine biopsies, and then analyze our results after some time. Again, we commend Dr. Thiri for this study that helps us diagnose SCC cheaply with results coming fast enough, just like you've seen Dr. Kabiru commenting. So many times we get patients who are for MDT, and all we need is a confirmation of diagnosis before engaging on more definitive management. That's my comment.
Thank you, Dr. Mnene. Professor Gishui.
No, I just want to commend Piri and just to encourage everybody in the audience that I think we don't realize the potential we have and what we know that the world doesn't know. So let's just keep working at our problems think he was very innovative, thinking about using impression cytology here. Submitted his work for publication. We had a disappointment with one journal, but he really went for one of the big high impact journals and was able to publish his work. So it's just to encourage all of us here. All these things we are able to do. And congratulations, Piri. Thank you.
Thank you. Thank you.
Thank you. Any final comments, Dr. Phil?
Thank you so much again. Like I mentioned, it's a privilege, it's an honor. I think I even mentioned this to everyone I've worked with, that sometimes I regret, I wish I was an ophthalmologist. So you guys always make me feel home and welcomed, so I really appreciate it. And I hope that we continue working the same direction and path around OSSN, and I will try as much as possible. And maybe another call to everyone that we should try as much as possible to devise ways to ensure that there's at least minimum exposure to harm to our patients. Thank you again for this opportunity. I hope, if possible, whenever I'm considered, I'll be in. Asante sana.
Thank you so much. Thank you for your attendance. Thank you for the opportunity also to moderate. I give back to Wanjiku.
Okay. Indeed, thank you everyone for your time and for your patience, and thank you to Dr. Piri for the great presentation, and the moderator as well. You are really good at this. And let's see you next month for next month's CMEs. Have a great evening.